welcome to this warm-up online session for the 5th International CRAFTA Congress. Today, we are going to be looking and focusing on some different cases on oral facial and cervical pain and dysfunction. We've got Dr. Mariano Rocabado and Dr. Harry von Piekartz, and they will be giving some very specific cases and going through some different ways of treating these types of problems. I am Jennifer Nelson, your moderator, and I am a physical therapist living in Rochester, Minnesota. I will also be giving a talk at the Congress talking about the pelvic floor and TMJ connections. I started off as a general manual therapy orthopedic physical therapist and was drawn to working with people who dealt with a lot of chronic pain. As I dove deeper into this, I found that a lot of things that we were talking about in the orthopedic world had a lot to do with the pelvic floor, but no one was really telling me how to treat this or how to really assess it. So I jumped into learning more about that. As I started learning more about patients with the pelvic floor problems, I noticed a lot of them also had some cranial oral facial problems that were not getting better with other treatments. So I started looking for some more resources on how to treat these people. In my fellowship training, I did have some exposure to some of Rocabado's ideas, and I started to look for more classes, but he wasn't teaching much in the States, so I'm extremely excited to get to hear him talk today and at the conference. Instead, I was able to find the CRAFTA classes that had just started coming to the United States. And this is how I met Harry. And from there, I learned, which was really great, because the CRAFTA approach, it really incorporates a lot of different biomechanics and pain sciences, which I hadn't really seen these two really applied together. So it really helped me when I was learning more about how to treat the pelvic floor patients, because we use a lot of these same things for pelvic floor patients. And as I started to apply these concepts to pelvic floor patients, I noticed a lot of them were getting better as well. And then I started introducing more of the breathing and the jaw treatments, and they started to get better even more. So I will be talking more about that at the conference, which is going to be in June on the 7th and 8th in Hamburg, Germany. There will also be speakers from 11 countries in multiple disciplines, and they all specialize in cranial oral facial region. There will be talks about dentistry, exercise, tinnitus, facial expressions, pain, and implants. There will also be a talk by Dr. von Piekartz and Dr. Olivio about the updates on assessments. I find this to be extremely helpful because as I'm very clinically focused, I don't always get as much time as I would like to stay up to date on as much of the research. So these types of talks are really important for me. Dr. Rocabado will also be giving talks about some pediatric pediatric patients and posture treatments, along with some musculotherapy patients with complex orofacial pain, both for the past and the future. So I highly recommend trying to tune into these talks. They will be in Hamburg, Germany, and this will be a smaller conference that really allows us to be a little bit more intimate and really get some access to the speakers and to really get to chat with each other. I prefer smaller congresses personally, so if you also enjoy them, this will be a good one for you. If you can't get there, it will also be available online. Conference will be taking place day one on a small houseboat that has been turned into a conference center, so it will be a beautiful setting. And then the second day will be just down the street, and there'll be classrooms, which will make this a lot easier for different breakout sessions. So enough about the conference. Let's go ahead and talk a little bit more about today's talks. First, we have Dr. Mariano Rocabado. He is a professor at the university in Chile and is all ready for a case study right now.
Okay. Well, hello everybody. Let me get my presentation ready. Can't see it in full screen.
Yeah, final case, a political problem.
Okay, we'll do it this way.
Yeah.
Okay, I'm sorry about the mechanical problems of computers. Okay, what we're going to be talking about, as I said, is a very complex topic. If we look at the craniovertebral joints, mainly related to the first three cervical vertebrae, in the process of relationship of craniocervical, craniomandibular, and what is referred as occlusion at rest, the tricentric concept, starts from a very early stage. The pattern that you're seeing here is basically that the process of growth and development, it depends actually on the position of the transfer process of atlas as the first cervical vertebra. And it's a circular pattern of growth. You can see that all these circular patterns are not only influencing the growth of the cranium, the growth of the face, and also influences the growth and the patterns of occlusion, how the teeth at the end come together. If we look at this process, looking at the way atlas is referred to the cranium, when atlas or the craniovertebral joints, atlas and axis relationship specifically, in the pattern of growth and development, can cause 6 different patterns of abnormal relationship of the craniofacial bones. We can see on the first slide on the top left, the heights of the maxilla is going to be asymmetrical. The length of the ramus is going to be different between right and left. The inclination of the frontal views of the ramus of the mandible, they're more obtuse, more open. You can look at the inclination of the sagittal ramus or the length of the body of the mandible and the height of the body of the mandible. So the craniovertebral joints are not in what we call centric relation. In a sagittal plane, in a coronal plane, and also in an axial relationship, we will have facial asymmetry, basically related to these 6 factors. So if you look at this case that we're going to be going through, you can see the facial asymmetry. It's a case that you can see that the left orbit of the eye is high, and the left corner of the lips are also high. It's a high condition on the left. Whenever you see an asymmetry that is high on one side, it's always a craniovertebral asymmetry. This is a case that went through orthodontic treatment for many years, trying to level her occlusion into an horizontal position, even though the craniofacial bones were asymmetrical. If I look at her profiles, you can see the way the head is sustained in a left lateral view and how the head is sustained in a right lateral view. The way she turns the head towards the left side or how she turns the head towards the right side, you can see that the patterns of movements of the craniocervical region are also asymmetrical. If we look at an axial view of the craniofacial region, you can see the asymmetry of the mandible. You can see that actually the skeletal midline of the maxilla that is shown there on the lip alignment is also asymmetrical. Look at the ears. Look at the right ear and look at the left ear. Look at the levels of the ears. That is showing that she has a severe craniomandibular, craniofacial asymmetrical condition. Why is she in my practice? In my practice basically is no pain, no patient. Every patient that is in my practice, no matter what age, pediatrics, newborns, or adults, have headaches and facial pain, basically. So this is a case that comes into my practice with headaches, supraorbital pain, temporal headaches, and also relating low back pain, as Jennifer was relating to the pelvic floor, how it relates to the craniofacial region, and lumbar pain. So it's a very diverse type of patient. We look at her occlusion. I don't know if you see my arrow. Can you see my arrow, Harry?
Yes.
Oh, yes?
Yeah.
Okay. You can see that her midline of the maxilla and the midline of the mandible are not aligned. It's deviated towards the left. In this observation, you can see that even though she's been in orthodontic treatment for many years, she's a relapse case of orthodontics. In a lateral view, if we try to see that if she has any disocclusion, we will see that her canines are not actually giving her disocclusion, especially on the left side, so she's not protected. Her lateral patterns of movements are basically symmetrical and proportional to the left and right, and you can see that in protrusion, she's moving actually on the midline. So dynamically, she is a case that has a normal 4:1 ratio, that for every millimeter of lateral excursion, she should have 4 millimeters of opening of the contralateral joint. So the 4:1 ratio is correct. She comes into my practice wearing an orthopedic removable appliance, a splint, that is increasing her vertical dimension extremely or probably too much. And we know that when you increase vertical dimension, in 90% of the cases, you will have a posterior rotation effect on the cranium in the upper cervical spine. So we immediately took away the splint, which is a condition that will take her into a new craniomandibular alignment. Even though the appliance was trying to maintain a stable occlusion, you can see that the appliance is not giving disocclusion, especially canine, to protect actually the joints. So we avoided the appliance to avoid increased changes at the level of the craniovertebral joint. It was an upper appliance, full cover appliance. If we look at her X-ray as an anterior, posterior, craniofacial cephalometric analysis, look at the position of the orbits of the eyes. You can see that the left eye is high. She was high also on her occlusion, but with the orthodontic treatment, they tried to level basically her occlusion to be horizontal, even though her craniofacial relationship was in an abnormal position. We analyzed her craniovertebral joints, and I'm going to go very fast on this case. If you look at the anterior-posterior mouth open view, and we rely on this X-ray very much, you can see that the lateral mass of atlas on the right side has a huge space with the odontoid process that is covered here by the incisors. This is showing that atlas is basically subluxed towards the right side. And by having a right rotation of atlas, her transverse occlusal plane could not be horizontal. So we look at the concept at the level of the craniovertebral joints and this asymmetry. We have this very interesting slide that says that the convergence of the cervical and the trigeminal afferents on the second-order neurons in the trigeminal cervical nucleus may refer pain from the upper cervical spine into the head and face. Furthermore, bidirectional interactions between trigeminal and upper cervical afferents may also explain neck symptoms of trigeminal origin. So this is something that we have to maintain always in mind in these cases. So if we look at the trigeminal cervical nucleus, we see that there is a connection between trigeminal 1 with the first cervical nerve root, trigeminal 2 with the second cervical nerve root, and trigeminal 3 with C3 branch. So the trigeminal cervical nucleus connects on a 50% concept anteriorly and a 50% concept posteriorly. So the supraorbit pain and the headaches in the frontal region that this patient presented was actually a trigeminal cervical nucleus problem. If we look at her average anterior-posterior x-rays, you can see the inclination of her head. That was the reason why the medical doctor that saw his case initially said this patient needs to go to an orthopedic manual therapist for correction of the craniocervical misalignment. Dynamically studied, we saw that actually there was a hypomobile condition at the level of the craniovertebral joint, especially in flexion. What was interesting on this case if you look at the initial case, this patient presented a retracted sternocleidomastoid muscle on the right side, especially the clavicular portion, that was actually not allowing the head to go back to the midline. So I talked to the general surgeon, and I said that I needed to disinsert the clavicular portion of the sternocleidomastoid muscle. We did that immediately after we started to evaluate the case, and we saw that after the first appointment, the patient was already able to do lateral rotation of the cranium and the correction of the position of the head in the cervical spine. Immediately after we saw the patient, probably after 5 days after the surgery, we started to instruct the patient in how to self-correct the lateral rotation of the cranium towards the left side, not to, or to prevent the retraction of the clavicular portion and the sternal portion of the sternocleidomastoid muscle that we have just done through surgery. We did some isometric muscle contractions of the muscles on the left side to control the position of the head as neuromuscular mobilization techniques and neuromuscular techniques to correct the position of the head. We taught stretching techniques for the cervical spine, craniocervical, and how she could correct the position of the head, especially in side bending to the left with rotation towards the opposite side. After surgery, initially after surgery, with a slight training on craniocervical alignment, you can see the change of the position of the head and the face. Look at the right picture of the initial case, and look how the case is changing. Facial symmetry is coming along with the initial phase of treatment. The head is now basically perpendicular to the shoulder girdle. You can see that the head is aligned with the cervical spine. She's happy. Why is she happy? Because now she finds that that is the type of face that she has to have. Initially, look at the face, look at the asymmetry, and look at the initial changes, even on her smile. Look how she rotates her head in a neutral position. We still have to work in an anterior-posterior view, but if you look at this way the head is getting symmetrical and facial symmetry is coming along, is what's keeping this patient very, very happy. She can side bend her head to the left and rotate to the right. The flexion rotation test of atlas and axis becomes more symmetrical and proportional. Third control after the post-operative technique. We start working in the lateral rotation of the head. And don't forget that when you laterally rotate the head towards the left, C2 rotates towards the same side of the lateral rotation of the head. So we start mobilizing C2 in left rotation together with left lateral rotation of the cranium. We initially started, together with that, techniques to start working on the normal alignment of the craniovertebral joints, trying to find the position of C2, and laterally rotating the head and laterally rotate C2 towards the same side of the rotation of the head. This is an Adler ligament technique to derotate C2 and to derotate the cranium to the same side for correction. So, according to what we have been seeing through the years, these patients, what they lack is actually the ability of the anterior cervical muscles to be able to hold the head on the neck in the right position. So we activated the rectus capitis anterior minor and major, especially to provide a holding mechanism and a very stable position of the head in relationship to the cervical spine and in relationship to the rest of the body. Actually, to come back and the head to be able to stay in the upright position. So we worked basically on the craniocervical muscles. We stabilized the craniovertebral joints by using a floaty on the cervical spine that you probably know all these techniques in relationship to the ability of the cervical spine to work and stabilize the prevertebral muscles and also the paravertebral muscles. You know the mechanics of the stabilizer. Well, I don't use the stabilizer that much, but I use the regular floaty, simple things that little kids use to go into the swimming pool to protect and to work the prevertebral muscles as well as the paravertebral muscles, using the floaty on the occiput, the face being parallel to a table, and producing pressure posteriorly to activate the muscles of the paravertebral cervical spine. So we use many techniques to allow the head and the neck to go into a more stable position. Here, we're working basically at the level of the craniocervical region, putting our fingers on the spinous process on the left side, holding the head and laterally rotating the head and mobilizing C2 in left rotation at the same time. So orthopedic manual therapy is mandatory in every case of craniofacial conditions. So we're doing the lateral rotation of the head, using nasion as an axis of rotation, and mobilizing at the same time the lower cervical spine. Then we mobilize the lower cervical spine, the facet joints, to allow also the head and the cervical spine to be adapted to the right position. So we use the cervical roll, all the floaty to stabilize the cervical spine. Force control post-operative of the same case. Now we're using the floaty on the occiput. Distraction, the patient will produce pressure posteriorly and at the same time control the lateral rotation of the head. Very simple techniques to work on the craniovertebral joints. And then you're pushing back and towards the left side.
Two more minutes.
Okay. So we work with the patient in different positions. Lateral side bending with rotation towards the opposite side to activate the left sternocleidomastoid muscle and inhibit the right sternocleidomastoid muscle. So we use that very much. We do motor control, activating the floaty, and at the same time with TheraBands, we increase the resistance of the craniocervical region. We work prone with the patient. We do distractions, prone. We teach them how to support the head against gravity and how to function in the three planes of space. So we see the effect of the treatment. We see them on X-ray. You can see how the head has been changing the position actually in a short period of time. Sorry, went the wrong way. We control the anterior posterior mouse open to see how atlas becomes more stable. The patterns of movements dynamically, we always control basically with images of the area. And we can see the changes of normalization. This was the beginning. Now we see that the lateral view is completely different. The dynamics of the head and the neck is normalized. We see the changes on symmetry of the face. You can see that now she can side bend and laterally rotate and actually rotate on atlas on axis without any problems, and her head is fitted in an horizontal position. Here comes the political problem. Look at the pre-op and look at the direction that the mandible is focusing. Look how the mandible is after treatment. It's completely to the opposite side. Look at the position of the nose relative to the mandible. So we're talking a difference basically on 6 months treatment protocol. Look at her face before and after. In red, you can see before the inclination of her occlusal plane. In white, you can see the inclination of the occlusal plane after treatment. So if you look at the two faces, look at before, look at the left and right orbit level. Before, the right orbit was down and the left orbit was high. After treatment, now the right orbit is higher than the left orbit. Look at the symmetry of the face. So if you look at her before and after, look at the symmetry of the face. And she says to me, this is the face that I like. But now, what's going to happen? I have to send the patient back to the dentist and say, you have to start all over again. This is a relapse case of a malocclusion, a craniofacial asymmetry, treated with a dental point of view, trying to level the occlusion when the problem was a craniovertebral misalignment, creating the craniofacial asymmetry. And once we level the face, look at the orbits of the eye, they are horizontal. Now the occlusion is her right occlusal position to restart all over again. And that is the political case that I wanted to present and share with you. That's it.
Thank you. Does anybody have any questions? I haven't seen any in the chat.
I think, Jennifer, we have first do the lectures and then the questions.
Oh,
Okay.
questions at the end. Sorry.
Yeah.
Yes. Go. All right.
Okay, that would be better.
All right, then. We
Okay,
will go
so
After this interesting question. So, yeah. And the goal is also the craniocervical complex. As we know, Mario already talked about the political things, is that if you look to the medical world, we see that neck pain is defined as a sensation and discomfort of the line of neck area, of the dorsal part of the ear and to cranial. So this is a territorium for neck pain. And the International Classification of Headache define face pain, everything from the supraorbital medial line up to the orofacial region. So what you see here, from the lower part of the eye up till lower, is for the, let's say, orofacial surgeon, or for the dentist. And we have a subclassification, and it's called TMD, temporomandibular joint dysfunction. So temporomandibular joint dysfunction is a subclassification of orofacial pain. And every vein between the red line and the green line is called headache. So in the medical world, it is the territorium are based on anatomical landmarks. And there's a lot of debate, also if you look to Cephalia, and also in the Journal of Orofacial Pain, they debate to change the lines, to say maybe we have to do the interorbital medial line change to the OME line. So in a very nice article from a famous neurologist from Hamburg, Anne May, he said, now maybe for neurologists, we have also to look to eye pain, which is also related with, for instance, migraine. But for us as a physical therapist, this is a strange classification, I think. So there's a lot of discussion on that. So as a physical therapist and manual therapist, I cannot live with that. I have to go in this territorium. So I want to give you Lizzie. Lizzie was a patient of mine 1 year ago, and she came as a young woman from 20 years old with a persistent unilateral cranial cervical facial pain. And interesting was that he had seen 2 physical therapists, manual therapists who...
Working camera that shadow rapidly.
Sorry, can somebody has the microphone on? Can you put it on, Christina? Is it? Yes. Sorry. Thank you. The manual therapist, he had an osteopath who treated a chiropractor. On the other hand, a psychologist. She met a psychologist, yeah, because maybe she had psychosocial problems. A neurologist, a dentist, yeah, and a specialist TMJ dentist, and an oral surgeon. But nobody could really help her. So if we look to this anatomical landmark classification, what probably is also good, but probably not for all patients, especially when they have a functional and pain problem. As Mariano also said, a lot of people come with pain, but pain is an individual experience, and we can explain it on different ways. If we look to the approaches from how we look to oral cervical pain models, we see that it starts already a long time ago. And in the first years of the last century, we saw the dentists were very interested in it. But also then, I think in the years 80, came Professor Mariano Rocabado on, and who said hey, listen, there can be by a TMJ problem also something in the neck and also controversy. And that was for us also a very good hypothesis or basic to work more on physical therapy in that area. Together with other models like the functional models, yeah, where you go away a little bit from the biomechanical point of view, but look on classical functional positions, multifactorial and biopsychosocial. And in the last decade, we see more comprehensive models, where you combine biomechanical, functional, but also neurobiological factors. Yeah, and you look to the whole complex of a patient. And that is a little bit why I want to talk about it. And we as physical therapists and manual therapists, we can swap also. We can go a little bit more in the biomechanical thing. So like Professor Rocabado explained on his patient, very nice. Yeah, and we can also go more in the neurobiological models of explanation or patients. So now what I want to do is a small focus on the orofacial cervical complex about the pain mechanism in the brainstem and the brain. As Rocabado also talked about the trigeminal nucleus. As we know, and everybody is probably familiar with it, yeah, if we have an efferent nociceptive input, what you see here in the ganglion trigeminal, yeah, I can get an efferent input, and you follow the blue lines. This comes in the oral part of the trigeminal cervical nucleus, and that is connected with the caudal part of the trigeminal cervical nucleus, and let's go to the motor system, pathwise to the thalamus and the somatosensory cortex. So if I have a nociceptive input from, let's say, the capsular from my TMD, yeah, I exactly know, okay, this is the surroundings of the TMJ, or if it is a trigger point in the masseter. As we also know that in cervical input, and now you follow the red lines, have also input in the nucleus caudalis and can be connected with the neurons of the trigeminal nerve, which is coming from the oral part of the trigeminal cervical nucleus. And that goes in an ascending way to the thalamus, but also to the motor complex and the somatosensory cortex, where I also experience my pain. So oftentimes the brain doesn't know where the pain is coming from. Comes the pain from the nociception from the orofacial region, or does it come from the neck? Yeah, and it is let's say a mishmash from a neural pool what comes into our brain. And if we follow this efferent input together, to the thalamus, it comes into our brain. And as we know, we have a kind of a neuromatrix. So there's an activity from this regions like the prefrontal cortex, the orofrontal cortex, the insula, the hippocampus, who plays a role, and the somatosensory cortex, who forms a kind of a neuromatrix, after this efferent input. So also, for instance, emotion or psychosocial factors or a cognitive element can influence my pain experience in the face. So at the end, it starts with this, what we call trigeminal sensitivity. By an increased trigeminal sensitivity, which is coming from the trigeminal nerve, together with the efferent input from the cervical spine into the thalamus, can give us a memory of pain related also with cognitive and emotional factors. Of course, we have also an endogenous analgesic system. And as we know, are we happy? And Professor Mario Rocabado said already, his patient was smiling again. And why? Because a lot of endorphins, and serotonin is coming free, who damp down the pain, into the whole system. So the interesting thing is also, you can have a long-term cervical problem, or a TMD problem, or an efferent input from the TMD plus the cervical spine, who give no pain. You have no pain experience, but then suddenly it comes. There's one factor. Maybe it can be a teeth treatment of the dentist. Maybe it can be a very small whiplash-associated disorder, or it can be a cold. And then you see a cold disintegration. For instance, you can see it like how you can explain this also to the patient. And I used it also by pain neuroeducation by the patient. So this is your working day. You start at 7 hours in the morning. You work, then you do your sport activity. You go to home, maybe you have some meetings, and you have a stressful conversation. So a sudden aspect is that the headache and the tinnitus, for instance, coming at the work situation. Or later when you are home, when you are tired, you get your headache and tinnitus. Or you get your headache, tinnitus, and neck pain after a conversation. So there's an increase of trigeminal sensitivity by efferent input from the neck, but also from the orofacial region, related with the context. But you have also an endogenous system. And maybe by sport, you make more endogenous or adrenaline or for instance, serotonin free, and that damp down the increased trigeminal sensitivity. And so on. So also in the night, maybe you make less free, but then in the morning, you first have an increase of endogenous analgesic system, and later on, it starts with pain because it is less. And so we can say that trigeminal sensitivity is accumulative. Pain not always is related with activity. And so sometimes you find signs in the neck by a patient with TMD problems, but can still have a problem. For instance, by the patient what Mariano Rocabado has. You had the first probably had no dysfunction, no pain, but she had still dysfunction. There's a history of multiple minor triggers. Maybe a small teeth extraction or a malocclusion with a bad splint. Influence of contributing factors. Maybe stress or risk factors. Maybe had an otitis media for a long time as a child. And then you get spread of the problems. You get maybe first cervical problems, then orofacial, and vice versa. Or it is spread over the whole body. You can get thoracic spine, lumbar spine problems. And it also influences the efferent system for instance, the autoimmune system, but also the motor system. And so if you look to the motor system, of course, the motor system, reacts also on dysfunction, on biomechanical dysfunction, but also on ongoing nociception. So you see also the blue parts in the brain are the overlap of the regions, who are overlapped also with pain experience. For instance, by a long-term nociceptive input and therefore a trigeminal sensitivity. And that can give motor output dysfunction. For instance, you get what you see here by this patient, monotone movement. Somebody do a protrusion of the jaw and you see no stabilization of the neck. You can see a mouth opening with no stabilization of the neck, or you see cervical movements, physiological movement, a lot of associated movements from the mandibular, or you see, for instance, abnormal eye movements. For instance, somebody gets a diplopia, or a strabismus, and therefore are also again consequences. And so also if you look to this model again, a functional model of a balance where you see a disbalance in the trigeminal sensitivity, and you can also see different motor aspects like bruxism. Maybe the patient by an increased sensitivity starts more with awake bruxism or during the work, or the bruxism like pressing on the teeth started as an increase of trigeminal sensitivity, and that is a painful situation for the person because the endogenous system is reduced. So as a summary, you can say there's a sensory receptive response, what we see by us as a patient. The patient come to us with pain, for instance, or they have associated symptoms like tinnitus, vertigo, or head pressure, or they cannot concentrate, or they have a distortion from somatosensory presentation. So they feel that the head is, they dislike their face, for instance. They cannot have a perception left and right. There's a difference. On the other side, we have a somatomotor response. There's an increase of masticatory system. Motor eye system is changed, or there's a cervical or facial motor control changes. Chewing is not good, or talking. Somebody has problems with articulation, or is a cervical functional instability. And there's a lot of good literature also about it. That, for instance, myofascial pain here by trigger points, has directly related with mechanical neck pain. You can maybe also explain the patient from Professor Rocabado in this case is also there's a mechanical nociception. What can increase myofascial muscle activity? What can change also the occlusion? The occlusion can change the position of the mandibular and therefore also the cervical spine. Another study done here from Kutzert et al. They have a control study done by whiplash-associated disorders people with higher nociception in the cervical spine. And they look to EMG activity of the temporal muscle and the masseter, and the digastrus muscle was very important. And what they see is that there's a presence of myofascial pain in the cervical muscles, who plays a role by the function of the stomatogenetic system. So all the activities like chewing, talking, normal movement of the jaw. The study we did was done on TMJ and by bruxism patients. And we saw that, for instance, people who have bruxism have neck pain, and they have also neck disability. And we did it on the NDI questionnaire, and we saw that the neck pain in bruxism may really high associated with trigeminal cervical hypersensitivity. they had less impairments, but more nociception. So in the practice, you can have an oral nociception, no pain. If you have pain, you can get an orofacial pain, but you can have also on the cervical spine. So in distance, for instance, cervical. So if you test then the cervical spine, you find probably cervical impairments who are not positive. So you find false positive test. Yeah, or you find bound. You can have also the controversy. You can have cervical nociception, no pain, but have pain in the neck. It gives a local problem, but it can also give distance problems like here, yeah, in the temporal or the masseter region, and give false positive test. So it means, yeah, there's a lot of overlap, and therefore it is a challenge to look which area is more dominant by this patient, yeah, in relation with function, dysfunction, and also pain. So it's not easy to find a magic bullet. So a patient, what I saw for several months ago, she had a unilateral pain. She comes with neck pain, and it was this neck pain she had already for 4 years. She had several manual therapists, physical therapists, and she had some speech problems during long talking. And she said, my neck feels like buffalo. And let's show her this picture and said, yeah, yes, that is my neck. That is how I feel. And you see also a small prominence on C7, T1. And she had a lot of posture exercise, dry needling, massage, yeah, for her neck. She had also orofacial parafunctions, pressing, bracing during the day. This was increasing, and she said, when I'm angry on my husband, yeah, 2 times I'm angry on my husband, and if I am stuck in a traffic. Now, if you look to the questions, the jaw function limitation scale, she had 28, it's relatively high, so she had some impairments of her function of the jaw. And on the craniofacial pain disability index, there's another question, she had 15, so that's moderate, and the neck disability was very high. And so physical examination, I find a lot of myofascial sensitivity and trigger points. If you look to her cervical spine movements actively, we see that she had a clear extension restriction, rotation to the left, and a lateral flexion to the right. So we cannot go in detail, but if we see this pattern, we do some other tests like intervertebral movements, and you know that is probably an upper cervical spine, probably a C1, C2 problem, because normally C2 rotate, yeah, converse to the other side under C1, and therefore you see a rotation, a lateral flexion restricted to the other side. And that was also by the PAVM's intervertebral movements. I find it also. And we saw also that her tongue pressure was very nice, very less. So first with the tip of the tongue, yeah, you saw that she had no force. If you do it with a tongue depressor under 45 degrees, she could not hold it. If you look to the swallowing phase in the middle of the palatinatum, when you press under 20 degrees, she could not hold it. So she had also a clear tongue problem and hypoglossus problem probably. So we treat her. The diagnosis, yeah, if you look to the ECDH, yeah, and that was from the dentist, that was a myofascial problem with an awake bruxism. And we did treatment of the muscles. Yeah, what you see here, we did some stretching with trigger point treatment in a dynamic way. Yeah, that is what we also do on the CRAFTA courses, where we, yeah, move the trigger point lateral and then move, yeah, in this kind, the anterior temporal muscle, yeah, and try to stretch it. And this is not painful. Yeah, this is less painful. And you to do it up till there is a release, that there is more movement. Yeah, in this case, in the anterior posterior movement, or the medial thyroid muscle. Yeah, small movement with trigger point treatment. Yeah, where we do open and do a lateral torsion and then come on the trigger point. Yeah, and move. Yeah, lateral of the trigger point. Yeah, you can, if you do this very well in a lot of cases, you can come with your finger under the medial side of the mandibular. So this was directly after therapy. Yeah, we did nothing in the neck. Yeah, you see also that the neck extension bears much more. You see also that the activity of the sternocleido is much more, which is normally when the head goes more than 45 degrees in extension. The rotation to the left. Yeah, you see also here a little bit red face because we worked on a masseter. And we see also here, yeah, that her rotation is less extension and more in an coronal plane, yeah, and less painful. So after 3 treatments in 4 weeks' times, we saw also that the neck disability was reduced, yeah, from 9 to 39. Also, her bruxismus, she could cope with it better. There was a postural change, so we look to her craniocervical angle here, yeah, about T1, T2. Yeah, you can do that very easy with a measurement, and it was first 47 degrees, now 24 degrees. Yeah, so she also liked it, and she had not the feeling anymore that she had a buffalo neck anymore. So to explain it from a neurophysiological background, you can say, okay, there's nociceptive input coming from the orofacial region, yeah, hits the trigema-cervical nucleus, goes further, change the masticatory muscles, and also give a pain experience. So we blocked here the efferent input to the trigeminal ganglion, and blocked also or changed also the input to the somatosensory cortex and later also to the masticatory system. Yeah, and this is also easy to explain to the patient, and of course also to the craniocervical muscles. So conclusion, you can say, general, there's a fundamental evidence in the relation between orofacial cervical regions. And I think also what Professor Rocabado said about his years of experience and his really good description of case studies. You can see, you have to be convinced that there is a very strong relationship. You cannot divide it. So what is done in the medical world? Most clinical studies support the positive influence of the craniocervical interventions on orofacial dysfunction and pain, in contrast to the reverse relationship. So there's a lot of evidence also, especially also from physical therapists. And there's a lot of, at this moment also reviews coming up. So benign craniocervical dysfunction and pain often do not confirm the standard diagnostic classification, as we described. So we see a lot of patients who have a maintained pain problem, and they are very young. Yeah, they are 10 years, 8 years. I see also patients who are 8 or 10 years, have 2 years pain. And if you look with a functional eye, and you can explain it neurophysiological, yeah, it can be very easy. So thank you very much. This was my lecture. I want to have to invite you also on those congress. I hope you can come. So what Jennifer also said, we have it also online. Yeah, and you can also see all the lectures for 3 months. Yeah, so if you have you get a code and you can see all the lectures in 3 months. This is the lecturing. I think we have a very good content from a lot of good lectures over the world. And also I want to emphasize on the congress, post-congress course we give. Professor Rocabado and I in Physio Edu in Gennep. That is in English. Yeah, we give a 2-day course on this orofacial cervical region complex. Yeah, where we go in depth also in not in we do a lot of practical things. Yeah, so that you can work with it, and we'll bring also the latest evidence. And the same course is also 13, 14 June in Istanbul by Midikurs in Istanbul. Very good organization in Istanbul who organize this course also. So thank you for your attention. Okay, I saw that my camera was out.
All right. Thank you. All right. Does anybody have any questions?
Did somebody say something in the chat, Jennifer?
No, they just said thank you so far. So, all right. I'll start some questions. All right. Mariano, I was just wondering what made you decide to refer the patient back for surgery instead of trying to work on the sternocleidomastoid yourself first?
Can you hear me?
Yes.
Actually, it was a very fibrous tendon
Gotcha.
that did not give with manual stretching or exercise. So it was a very easy decision and a very fast and positive decision from the orthopedic manual therapist to the surgeon that accepted the prescription of the physical therapist.
We have one question, and it's Mirjam is asking what surgery was performed exactly for this patient.
The disinsertion of the clavicular portion of the sternocleidomastoid muscle, not the sternal portion, only the clavicular portion. Very fast, 5 seconds.
And then
Mariano, maybe can Mariano do his camera is blocked, maybe.
Let me see, where am I?
Or yeah.
excellent.
Nice to
And
see
then,
you back again.
And then
When when the surgeon comes in with a little hook type of how you call it, incision maker, he finds the clavicular portion, hooks around it, does this, and that's it. Because then that portion just raises up and reattaches further up. So it allows the movement of the head to move away from the clavicular portion. It's the clavicular portion, not the sternal portion. But because the clavicular portion is the one that is in charge of doing the lateral rotation of the cranium. Mm-hmm. So if you disinsert the clavicular portion, then your head can move away from it.
Erdem had a follow-up question and is wondering, when do you start exercises after surgery? How long?
5 days after, basically.
All right. All right, Harry, I have a question. Just wanting to know, how do you approach the idea of accumulation with your patients, both gathering the information and then talking to them about it?
You mean how I explain the patient about that the nociception come from both ways, you mean?
Yeah, and yeah, that part, and how there might be some buildup from throughout their day and different things contributing to it.
Yeah, okay, that's good, because as you saw this patient, so I could convince her that that by treatment only in the orofacial region, her neck becomes better. As she saw that directly after the treatment. And so in this case, by her, it is probably also a lot of motor system, motor pattern changes. And so this is what you can use. So you have to start step by step. Sometimes you see also that if you have a dominant cervical problem and you get a reproducing sign from the cervical spine, and the patient had also orofacial dysfunction, like the mouth opening is restricted, or you see a shift or a deflection, and you measure that, and you let's show the patient that in the mirror, yeah, they are convinced about it. Yeah, and they say, okay, you see that the neck and the orofacial region has to do with each other. Yeah, sometimes I let also do the patient, let's show them a protrusion of the jaw, and they see that the sternocleido is increasing. Yeah, or when you do a jaw movement, a special protrusion, yeah, or the lateral tusion, that you feel that the deep muscles is activated. Yeah, so I let's show them that it isn't the thing was coming in, it comes in a pool, and this pool, that is the, let's say the bucket where the train cervical nucleus, which gives information to your brain, because the pain is in the brain. So this is how I explain it very, very carefully, step by step. And so that also the exercise you have to do, yeah, are cervical, but also orofacial problems, orofacial movements and exercises.
All right, we've got another, thank you, Harry. We've got another question in the chat. Are there any special clinical differences in headaches following vestibular schwannomal surgery?
I think this is a question for Mariano.
I don't know.
Can you repeat the question again? Sorry.
Are there any special clinical differences in headaches following vestibular schwannomal surgery? Specifically, it looks like the the left vertical or the retral sigmoidal approach.
I have no idea.
No idea.
Sorry.
Okay, good. It's like a good research.
Interesting question.
That question is a good question for your neurologist friend, that you can talk to this with a beer in your hand or during a lunch or a dinner.
For the
But
conference.
it's not a question for us.
Sounds good.
Yeah, I agree.
Okay, all right, now we've got another question. How do we know that we have achieved the maximal results that could have been achieved by physical therapy? Would it be a complete absence of pain or disappearance of visual deformities? And then how do you understand? Just want to know when and why should we stop? I think this one's good for both of you.
Well, in my case, I never tell the patient that I'm going to solve the problem. I'm going to help her, and her signs and symptoms are going to diminish. Like we always say, 70% is going to be a good result, but never 100%. Why? Because there's tissue damage. Once you have tissue damage, it's very difficult to repair. So you can help them signs and symptoms, but you will never have 100% success. There was always going to be a relapse on the situation. So don't commit yourself that you're going to treat the problem in 100%. If you do it on a 70%, it's good. If you do it in 80%, it's very good, but never 100%. There's tissue damage, deformation, joint degeneration, articular cartilage damage, many signs and symptoms that are related to conditions that we cannot actually help the patient.
Mm-hmm. Yeah, I think also, what we also have to be aware, especially because there are some complicated patients and they're also young, that the changes are going fluency, yeah, slowly, yeah. But you have also to, I think, also to reflect back with the patient from, look, you started 3 months with this, now we are here. Do you see the difference? Yeah, and of course, what the question also was, what is in pain? It is in function. Yeah, do you see that the function is better? Yeah, you can rotate a little bit further. You can open your mouth. Okay, so what? But how's your quality of life? Are you happier now? Yeah, this is also a very important question related with function. And I think also what important is, is there still a misperception in this area? I see a lot of, let's say, young women who get a retrognatic jaw, and they can decide to do an operation, to get an operation to get a larger mandibula, and they have to decide, okay, do I want to do it for the pain or for aesthetics? They have also this dysmorphia, body dysmorphia. Yeah, and that can also become by chronic unilateral headache and cervical and TMD problems. So also these are very important things. And I think also, as Mariano also said, you guide them to the process. Yeah, and this process can be relatively long. Yeah, it's not only in 2 weeks or 4 weeks, but maybe in half a year. Yeah, so that's my experience with it.
Yeah, and this is a very important point that Harry's trying to bring out, is the time factor. There is a time factor in your process of treatment. These are things that you cannot treat in 10 sessions, because most of the time the prescriptions may say 10 sessions of manotherapy or physical therapy. No, it does. It's not. It's a problem of biology. It's a problem how the soft tissues react according to the approach that you're trying to implement in that patient. Normally, we tell the patient, look, you have 6 weeks of treatment of pacification. Pacification, what does it mean? The name says it. Bring down and calm down your signs and symptoms. Make you feel better, make you move better, but the problem is not solved. If you have pain, it's because you have tissue damage. There's a rupture. Something is torn and has to repair. So you have a phase of pacification, bring down the signs and symptoms, and then allow the tissues that were torn, where you have a rupture, to heal. That's another 6 weeks. So you have 6 weeks of pacification, 6 weeks of repair. It will never take you less than 3 months. After 3 months comes a phase of stabilization. What does it mean? If it's on the craniofacial region, you may have to go back to the dentist, maybe have a splint in your mouth, maybe have to locate the mandible in the right position so that the joints, both joints, are not going to be under intra-joint compression to produce a relapse of the problem. How long is that going to take? Maybe another 3 to 6 months. So normally this case, in your hands, 3 months, and then at least 6 months to repair the condition in the odontological condition. So these cases are going to be under your control for at least 9 months. I never tell the patient 9 months. I always tell you it's going to take you 1 year. The patient is going to be under your responsibility for 1 year to stay pain-free with a normal functional, how you call it, amplitude of movement of whatever, call it on the craniocervical region or call it on the craniomandibular region. If the patient feels comfortable at that point, you've done a very good job. But it's not a problem of 1 week or 2 weeks. No, it may take you up to 1 year. Not every day, of course, maybe once every 15 days, maybe once a month, depending on the condition of the evolution of the patient. But don't forget that this is a time factor to allow the tissues to repair the damage that has been caused by any circumstance.
Yeah, and especially also, I think also the exercises patients do that at home, and the compliance of the exercises, is also related again with how you explain it, what the patient has, and what Mariano also said, the time factor, They have exercises and the explanation together.
All right. Mariano, another question for you is do you have any tips for those types of conversations with the dentist, where they may have been working on something and then you need to refer them back after your treatment?
Well, that's a good question. You have to invest. Maybe a beer, maybe a lunch, maybe a dinner, maybe alone or maybe with your spouse or your companion or whatever. You have to become a friend. If you're not a friend with the person that you're working with, where you can call him and say, I think what you did is not correct, he has to accept it. It's your professional opinion. You are a professional that has a special training on the area. Your opinion is mostly important in the process of the outcome of the treatment of the patient. But for that, you need to invest. Find a dentist, especially if the dentist is your patient. When the dentist comes in with neck pain because he's been working in this position for 12 hours a day, then that dentist will understand what a physical therapist or a manual therapist can do to relieve signs and symptoms on the head and the neck. You have to understand one very important concept. Dentists in dental school all over the world have no idea you exist. You don't exist for the dentist because they have never been taught in school that physical therapy exists. They have never taught in school what a physical therapist can do to treat a musculoskeletal condition. They don't know. So they don't know you exist unless you become a communicator with the profession. You have to communicate with the dentist. If a patient comes into your practice and says, Doctor, I have neck pain, sometimes maybe occipital pain, that's a TMJ case. What's the first question you should ask that patient? Who is your dentist? Not who is your medical doctor. Who cares? Medical doctors don't care what you do. The only thing they want is just get the patient better no matter how you do it. Dentists are different. So when the patient comes into your practice, headaches, neck pain, facial pain, first question, who is your dentist? What's the first thing you're going to do? Call the dentist and say, Doctor, I have in my practice a patient of yours. Now he's having neck pain. Now she's having a neck pain. Maybe because he had a fall, he had an automobile accident, or maybe he had a sport injury or whatever. But now he's in my practice, is my patient. So I would like you to see the case because I think his occlusal contacts, not the occlusion, occlusal contacts may have changed because of the head and neck trauma or the head and neck dysfunction or the head and neck myofascial condition. Patient comes into the dentist's office, sent by you to the dentist, but now it's my patient, sent to him. So now it's a mutual patient. He sees him. What's the first thing you think he's going to find? Changes on the occlusion. His occlusal contacts are changed. You call him by phone and say, Doctor, what do you think about his occlusal contacts? Not his occlusion, occlusal contacts. How are they in relationship after the trauma? For me, he has a high velocity trauma to the soft tissues of the cervical spine. And he'll say, his occlusal contacts are completely changed. I haven't seen the patient for the last 6 months, but on his records, this is not what the patient has. So what do you say? Okay, doctor, how about if we work together to make this patient feel better? It's a mutual concept. Dentists don't know you exist because nobody has taught them that manual therapy or physical therapies can do something in dentistry. You have to make the approach. You have to open the field of physical therapy and dentistry. How? Every patient that has a neck problem, the first question you must ask is, who is your dentist? And you call him and say, I have a patient of yours that is in my practice with a neck problem. Maybe tell him some story that looks nice. How about if we get together and discuss the case? Then he'll know who you are. Otherwise, you'll never know physical therapists exist.
Thank you. All right. Do we have time for one more question or should we leave it there?
I'm okay.
Yeah. Yeah, one more question.
All right, then I guess, Harry, do you have, what are some of the common false positives that you tend to see when you were talking about the trigeminal cervical nucleus? What are some of the common ones and how do you distinguish between the two?
Yeah, okay, this in relationship with the study we did by bruxism. Yeah, so we take people with awake bruxism and they had also neck pain. And so with false positive, wants to say that you find no cervical impairments, but there's still pain. So if you, let's say, do an unilateral posterior anterior movement on the C1, C2, it is painful, yeah, but you find no really tissue changes. Of course, this was a very, let's say, subgroup, yeah. But it can also be that if you have a patient with a long-term nociception from the masticatory system, that the trigeminal cervical nucleus projects on the head, on the brain, and says, okay, you have feeling the pain in the neck, but there are not really relevant signs over there. But if you press there, or if you do a manual technique, you can get reproducing signs. Yeah, we know reproducing signs in manual therapy are relative high in the hierarchy from importance. So that is mentioned by this. Yeah, so the same if you have a hip, yeah, you have a clear arthrotic hip, which gets his projection pain in the knee. So if you then do some passive movements in the knee, you reproduce the pain, or it is hypersensitive, yeah, that want not to say that it's also a knee problem. Yeah. Of course, we have to say that by the orofacial cervical complex, it is, of course, they are more connected with each other. Yeah. So, but we have to look to the relevance. How much is that relevant? Yes, that is, I think, the answer so far. Yeah, so false positive tests want to say that I reproduce it, but the original source of symptoms is not coming from that particular region, and you treat it. Yeah, for instance, we see that in the practice. I see that. Yeah, why by this patient also. So her sources of symptoms was more, yeah, in the TMD region, not in the neck, but she had neck symptoms. Yeah. Okay, so the cause of the cause probably, the changes of the tissue was more in the orofacial region than in the craniocervical region.
Thank you. All right, I think the last question that there was is just a administrative one, and wondering if this will be emailed out so that people can rewatch it at all.
Ah, yeah, okay. We discussed it. We with Professor Mariano or Rocabado. We want to set it on the CRAFTA education YouTube channel. Yeah, maybe it costs several days, but maybe we do on the website or on the Facebook and or Instagram a small messages that it is online.
Excellent.
Okay, very good. Thank you very much.
Yeah, thank you, Mariano, also for doing this, and I thank also Jennifer for for being the chairwoman. And we hope that a lot of people coming on the Congress. I think it is a very unique Congress. I think it is really a Congress for physical therapists, where also dentists talk about communication, collaboration, etc. So that's also a basic way for us, to work with the dentist group.
Yeah, I just want to make one very short comment. Don't forget, especially for manual therapists, that dentists always work under numbers, angles, degrees, millimeters. Everything is objective. Everything has to be measured. And if it's not measured, it's just an opinion and not a fact. You have to learn how to communicate with dentists in an objective way. Take pictures before and after. Today is so simple to do that, to see a progression of a treatment, to show that you are able to do objective changes in the benefits of the patient and for also communication. If you do not communicate with the dentist the way they are really dealing with the concept of treatment of cases, it's very difficult to find a common understanding. So what we did today, and I tried to show you in a way the case that I followed, to show the before and after, show the beginning and in between treatment, late treatment, a final treatment, to show the changes objectively so that the dentist can see that we can do objective treatments and not just also symptomatic treatments. That's a big difference. So I hope to see you in Hamburg. It's going to be a fantastic program. Harry, in that sense, has a mind like this. What he wants is physical therapists to be successful in a field of specialization on the craniofacial region. We're all going to be working in that sense to make it a very successful program. So I hope to see you in Hamburg. Thank you very much for inviting me to be with you today. Ciao, ciao.
Ciao, ciao. Okay, Jennifer, maybe you can close down?
Yeah, all right. Thank you everyone for joining us. We hope to see you in Hamburg. If you have any problems registering, just go ahead and email. It is a little bit different for people in the States, the payment option, or in Canada as well. We have a couple questions about that, but it is normal to do bank transfers, and that is the best place to go. Anything else? We just feel free to send a chat again or email to us, and we look forward to seeing you in Hamburg. Take care.